So we left off at the ethical situations, right? So this is like where all your questions pretty much come from. I love that first aid has this. There's a lot more than just this, but this does cover the bulk of things that can happen to you at a simple day at the hospital, right? So one of the most common is your patient is not adherent, right? So your patient doesn't want to listen. So the appropriate response stuff is all things that you have to do, not just to make sure you can offer your patient the right help, but also so you can make sure you don't lose your own license, right? That I told you in the beginning in the last video that all of these things aren't just there to provide patients the perfect help, but also to make sure that you don't get fucked over by the law. So what do? Your patient is not adherent. They don't want to listen to you. Attempt to identify the reason for non-adherence and determine his or her willingness to change. Do not do these things. Do not coerce the patient into adhering. Don't force them. Don't scare them. Don't try to convince them. None of that. And do not refer him or her to another physician, right? So you will, as a doctor, get a patient who doesn't want to adhere to whatever you're suggesting. Your immediate response has to be to ask why. And that's pretty common sense, right? A lot of these things are commonsensical. The only issue is that even common sense needs practice, okay? So with practice, that common sense becomes more solidified. Someone doesn't want to listen to you, it's always the natural response to say, why? Right? Why don't you want to listen to me? And then listen to why they don't want to listen. And then once you know why they don't want to listen, ask them how willing they are to change that, right? Is there a chance that you might listen? What would help you? What would be best for you? Okay. Now in the notes over here, any of these notes are from you, Rose. So over here I will say many patients find it difficult to take medication every day. Tell me more about what makes it hard for you. Normalize the difficulty and follow by open-ended and non-judgmental exploration of the reasons for non-adherence, right? So one of the most common non-adherence issues are that patients often don't want to take their medications. They just don't want to do it, right? You give someone levothyroxine because they have now been diagnosed with hypothyroidism. If they don't want to take their levothyroxine every day because maybe they have other medications they have to take regularly, or they just don't want to take it because they don't believe in medications, you have to hear that out, right? You got to understand it. Solutions for patients who are not adherent include simplifying the regimen, educating the patient, choosing generic or less costly medications, addressing side effects and psychological issues, and increasing supervision, monitoring, and follow-up. Right, so follow-ups are a big deal here. Yes, of course, with every follow-up visit I give to my patient, I'll make more money, but it's not all about the money, right? That's not what you want the patient to think, because patients do think that. I tell them, all right, I'll see you again in 2 weeks, 3 weeks, 4 weeks. They'll be like, no, I don't want to keep coming back. Why do I have to come back again so you can make more money? No, because you still need the help, and I need to make sure that you're adhering to what I've told you to take, right? How am I going to know if you're taking medications that I've given you? If I put you on a new medication for your blood pressure and you're not taking it, I'll know when you come in because I'll see your blood pressure, right? I'll know because your urine might have the metabolites of certain other medications I'm giving you, and so on. So a patient not being adherent is extremely common in the real world, and this is probably the most important one for everyone to know, not just for the test, but more so because in real life it happens. The other one is patient desires an unnecessary procedure, right? So there's always that malingering thing, right? So patients desire an unnecessary procedure. Attempt to understand why the patient wants the procedure and address underlying concerns. Do not refuse to see the patient and do not refer him or her to another physician. Avoid performing unnecessary procedures, right? So again, the common sense aspect of things, if someone comes in and they're like, I really want to get a colonoscopy, and they're maybe 30, right? So then you don't just go like, no, you don't need a colonoscopy, get out of here. No, that doesn't make sense to do. The correct thing that makes sense to do is to just ask them why they feel like they need a colonoscopy, right? And then they might tell you like, oh, my dad died of colon cancer, or my grandpa died of colon cancer, something like that. And then their concern is actually pretty real now, right? Depending on what age their father or grandfather might have died of colon cancer, you're supposed to start screening 10 years before that age, okay? So if his dad did die at age 40, then age 30 would be the right age to start doing the screenings for colon cancer. But you definitely avoid unnecessary procedures. Unnecessary procedures, avoid. Someone will keep coming in, be like, I really want to get an x-ray of my left arm. For what? Right? That still is, like, if you don't need it, then you're not going to get it done, and that's it. Now, if someone is really, really telling you they just need it, and there's no, viable reason for it, well, an x-ray you can go get done, but a colonoscopy, not so much, right? It's still, but for most things though, in all reality, for most things, if a patient is really pushing, they want to get it done, you go ahead and order that procedure, right? But procedure is a very powerful term, because then there are procedures that are really extreme, right? Those you don't allow just because they're asking for it, right? So if someone wants to get a prostatectomy, but they have no history of BPH or difficulty urinating, any of that, then there's no reason to get a prostatectomy. They're not going to work. It's not going to happen. So something like that you definitely want to watch out for. Patient has difficulty taking medication. Extremely common thing, right? And this is difficulty. This is not non-adherence. So difficulty taking medication basically means that I have too many medications and they have too many instructions. Some of them are eat with food, some of them are eat on an empty stomach, etc., and I'm having trouble doing it. Okay, so provide written instructions. Attempt to simplify treatment resumes and use the teach back method, right? Very important method, very amazing method, which is where you basically ask the patient to repeat the resume back to physician, right? And all of this is to make sure comprehension was there, right? So the patient understood what I've explained. Now, many medications do need to be taken on an empty stomach. And then there are medications that need to be taken at nighttime before you go to sleep, because maybe they cause orthostatic hypotension, or they are sedated, right? So you take it at bedtime at night and not during the day where you might start driving. So all of these things need to be provided, not just in written instruction, but also be explained, okay? And the teach back method is perfect for that. Even in the pharmacies, when you pick up medications here from the pharmacy, you're going to get forms in there, right? The medication packet is going to have a bunch of slips with it, and each slip tells you how to take those medications. So now it's not even so much of a doctor's job anymore. It's the pharmacist's job, where the pharmacist will provide you all the written explanation and instructions for how to take each one of those medications they came to pick up today, okay? But as far as step 1 is concerned, as a doctor, just provide written instructions and use the teach back method. Family members ask for information about a patient's prognosis. Very common thing, right? It's so common, especially personally, I've seen it in the Desi community, all the Indian, Bengali, Pakistani hospitals that, or doctors that I've generally worked with. It's a very common thing that family members will come in and ask for prognosis, and the doctor has to know you can't share someone else's private healthcare information with family members or anyone unless the patient themselves have said it's okay, right? So avoid discussing issues with relatives without the patient's permission. Now, on paper, this all looks great, but in real life is where it becomes really intimidating, right? If someone's wife comes up to you like, hey, how are you doing, Dr. Amir? Oh, I'm good. Yeah, basic conversation, right? We catch up real quick. So how may I help you? And then she'll be like, listen, I know my husband came in yesterday, and he came in because of X, Y, and Z, and he's been looking really tired at home. So what's wrong with him? How is everything? I am now in a real life position where I can't just pick an answer choice from, made up sentences and be like, tell wife that I can't talk to you about it, right? I can't even do that. I'm not gonna be like, hey, I can't talk to you about that. That's gonna be rude, right? That's gonna be intimidating. It might even make her go talk badly about me with other people. So on the spot, you got to make up something really good where you don't give away the patient's information to the wife, while at the same time you don't piss off the wife, right? So you're really stuck in like a really hard spot right there. And you got to pick the best answer choice that isn't rude, it isn't mean, it isn't evil, it's not fucked up, right? But at the same time, it also doesn't provide patient information. You don't provide it, okay? So you could say something like, oh, yeah, he was here, but, if you want to know more, how about we just get everyone back here together, and then we'll all talk about it together, and schedule an appointment where the husband and wife both come in, right? At least that way the husband knows that the wife is there, and if the husband doesn't want me sharing something, he'll stop the wife from even asking. And at that point, it's their problem. Something like that, okay? Next one says, a patient's family member asks you not to disclose the results of a test if the prognosis is poor, because the patient will be unable to handle it. All right, so now this is a very touchy situation where a daughter might ask me to not tell her dad what came out of the test results because her dad might not be able to handle it, according to her. Attempt to identify why the family member believes such information would be detrimental to the patient's condition. So I would ask her, why do you think your dad won't be able to handle it? right? Explain that as long as the patient has decision-making capacity and does not indicate otherwise, communication of information concerning his or her care will not be withheld, right? So then I'll tell her, after I ask her, why do you think your dad won't be able to handle it? And she'll be like, oh, I don't know, he's really old now, so I don't think it's a good idea. I'll be like, look, he can talk just fine. We've been talking about everything. He knows what's happening. I think he'll be just fine. So, just make sure you're there with him and take care of him. Something like that, right? So you can't be rude. That's one of the most important things. Where a lot of medical students mess up is they pick the answer choice that on book and on paper, by book, it looks correct. But it was rude, so you can't pick that answer choice. You see why now there can be multiple questions where two answer choices look correct? It's because they both are, right? But one of them is computer and the other one is more human. You cannot be rude to anyone, right? It's not going to work. So you do that thing, and then however, if you believe that the patient might seriously harm himself or others, if informed, then you may invoke therapeutic privilege and withhold the information. But you always only invoke therapeutic privilege if it helps the patient, not others. Okay? So, for example, say there's a husband and he came in for STD checkups, right? And I tell him something, or a boyfriend or a husband, anything like that. Say there's a man he came in for STD checkups, and I know that this other woman is someone he's having sex with. And this woman comes to me and she tells me, oh, can you please not tell him, if he has any STDs because I feel like he's going to beat me. Well, I can't do that. That's not therapeutic privilege, right? He's my patient. If he now has an STD because he had sex with someone, and you think that he's going to beat you because he's going to be mad that he got the STD from you, then you need to call the cops, right? But I'm not going to hold back information from him because that might safeguard you, right? Your first duty is to your patient, right? So therapeutic privilege, the therapy has to be going to the patient. Just like in this exact scenario, right? You want to avoid this because he might harm himself or others, but you're doing it because he is going to have an issue, not because someone else is going to get harmed, and that's going to be the problem. It's a very difficult way to explain this, but the harm others part, the one that I just explained with this woman thinking that he's going to beat her because he thinks he got the STD from her, whatever, that does not invoke therapeutic privilege. If he's going to do something to her and it's because he found out that he has an STD and he thinks it's from her, that's a whole different case, and it's not therapeutic privilege. But therapeutic privilege would be any case scenario where, I'm trying to think of where it would be where someone might harm others. I think the most common place would be like a pregnant woman who just gave birth, right? So she can harm her baby if she now has a new condition because she just gave birth to the baby, right? So something like that. But it's very rare. I've never seen something where it might harm others. Definitely harm himself, yes, right? So a patient might go ahead and commit suicide because they found out something about their own prognosis. And that's definitely a very sensitive place to be in. Now we're looking at abortion, right? So 17-year-old girl. So that's underage, right? In most states, that is considered underage because the general rule is under 18, you're a minor. So a 17-year-old girl is pregnant and requests an abortion. Now, many states require parental notification or consent for minors for an abortion. So it says many states here because that's the fact. But for your test, all states require parental consent for an abortion for a minor. That's all that matters for you, unless the question specifically says, oh, this patient is in this state, and in this state, the law is X, Y, and Z. Well, now they've given you extra information for you to work with, so that doesn't make sense anymore, okay? Unless there are specific medical risks associated with pregnancy, a physician should not sway the patient's decision for or against an elective abortion, regardless of maternal age or fetal condition. Okay? So what that statement is telling you, that unless getting an abortion will kill her, right? Unless getting an abortion will do something really bad to the mother, you will never tell the mother, hey, maybe you shouldn't get an abortion. And why would someone do that? Well, in Catholic hospitals in New York and in other places in America, they don't do abortions. They don't do abortions. But even there, they can't really try to sway the patient from getting an abortion. What they'll do is they'll send her to another hospital where they can get an abortion done, right? Abortion is against many religions, right? You can't use your religious understanding of things to try to sway a patient away from getting an abortion, okay? So the only reason you ever want to tell a patient to not get an abortion is if you think that getting the abortion might kill her, might destroy her uterus, and she might never be able to get pregnant again, right? Might cause some kind of scarring that might lead to endless bleeding because she has thin blood, etc., stuff like that, right? Only stop someone from an abortion because it'll be bad for their own health, right? So this is a 17-year-old. Wants to get an abortion, you get parental consent. Very straightforward, right? Nothing else. A minor may consent for prenatal care, but not elective termination because almost 1/3 of states require parental consent for an abortion. So what this is saying is, as I said earlier, right? Remember the wipe thing? So in wipe, in the last video we talked about where informed consent doesn't matter, right? So in wipe we had this, where is it? Sorry, not just that, the consent for minors thing, right? So sex, drugs, rock and roll. Remember under sex it said pregnancy right here, right? These are all the things that situations in which parental consent is not required, right? So pregnancy means that staying pregnant, you don't need parental consent. But it doesn't say abortion here, okay? So sex, drugs, and rock and roll is only for these specific things that are here. But abortion is a whole different thing. So what I'm writing here for this 17-year-old girl is that if she wants prenatal care, if she wants to stay pregnant, she doesn't need anyone's permission for that. She can stay pregnant. That's okay. But if she wants to get an abortion, she's too young to go ahead and give that permission herself. You have to get parental consent. All right, now a 15-year-old girl is pregnant in the next one, right? A 15-year-old girl is pregnant and wants to keep the child. Her parents want you to tell her to give up the child for abortion. Remember what I just said, right? Anytime you want to stay pregnant, you don't need anyone's consent, right? It goes against informed consent. Sex, drugs, rock and roll. If you need help with drugs, detox, anything else, if you need help with any kind of emergency stuff, the rock and roll stuff, trauma, or with anything related to sex like staying pregnant or STD help, you do not need anyone's permission. So this 15-year-old girl wants to stay pregnant and her parents are like, come on doctor, tell her to get an abortion. Like, stop it, right? The patient retains the right to make decisions regarding her child, even if her parents disagree. Provide information to the teenager about how to take care of a child, right? How to be a mother. Discuss the options if requested. If she wants to have ideas like, hey, what about an abortion? Should I get an abortion? Like, would that be a good idea? Only discuss the options if requested, though. That's what it says, right? Every word here matters. Encourage discussion between the teenager and her parents to reach the best decision. We talked about that in the last video too. Encouraging discussion between patients and their minors. Very important there. But you do not go ahead and talk to the child about abortion if the child isn't even asking you about abortion. Right? You do not go talk to the child about abortion just because her parents were like, hey man, you're a good doctor over here. You're a family doctor. We always came to you since like past 25 million years. You better go tell our daughter to get an abortion. You don't. You could tell the parents that you're sure, what are you going to tell the parents? You'll tell the parents, listen, let me talk to her. I'll take care of this. That's it. You don't tell the parents that you are going to go tell her about an abortion. You just say you're going to take care of it because you know how to do your job. You go to the 15-year-old girl, talk to her alone, no parents in the room, because she's pregnant now. Right? So whatever decision she needs to make about staying pregnant is completely up to her. Staying pregnant, you make the decisions. Getting an abortion, your parents make the decision. Right? This is all about underage people. Now, Akanksha is asking, do we need to know about specific state about abortion rule? No, you do not, which is why I'm telling you the general thing, right? So the general law that you want to keep in mind is that no matter what state, if you want to get an abortion and you're under 18, you need parental consent. If you want to keep the baby and you're under 18, you don't need anyone's consent, no matter what age you are. If you want to keep the baby, you keep the baby. No one can do anything else. And what's special here is that the parents were telling you, as a doctor, telling you to go tell the daughter to get an abortion. But look, then they say discuss other options only if requested. You don't go talking to a girl about getting an abortion and how an abortion works if she's not even interested in getting an abortion. Right? That's like unnecessary information, unnecessary discussion, and you're trying to sway someone in a different way. It's a very sensitive thing to be a doctor. Very difficult work here. You got to make sure you don't fuck up. Right? But you don't need to know every state's law or rule by itself. If there is a specific thing about a state, the book will tell you, like the question stem will tell you. But generally speaking, I've never seen a question where it does that, where they tell you, oh, in this state, by the way, it's not allowed, because then that would give you the answer, right? So all states, if you're under 18 and you want to get an abortion, you need parental consent, right? And if you're under 18 and you're pregnant and you want to keep the baby, you don't need anyone's consent. And the only special places about consent were that if you're already a legally emancipated person, if you're a 16-year-old girl who's in the military and you're looking to get an abortion, you don't need anyone's permission because you're already legally emancipated, right? If you're 16 and you're married and you want to get an abortion, you don't need parental consent. You're married. You're legally emancipated, so on and so on. All right, so I hope that helps. No problem. Next one is a terminally ill patient, right? So this is a sad one. Terminally ill patient requests physician assistance in ending his or her own life. Okay, very common thing as well. It happens. Overwhelming majority of states refuse involvement in any form of physician-assisted suicide. So basically, all states do not want physician-assisted suicide to be a thing. Physicians may, however, prescribe medically appropriate analgesics even if they shorten the patient's life. Right? So basically what this entire paragraph is telling you is that no state wants physician-assisted suicide to be a thing, but you can do it. Okay, and it's a thing where you're not going to go ahead and openly do it. Right? So you're gonna give them medications that is appropriate for them. Like they do need that medication, and then just, they can go ahead and overdose on it and they'll die. And that's it. Okay, so that's physician-associated suicide, right? Some kind of analgesic that is medically appropriate. They need it. Maybe they're having trouble sleeping. Document it like that. And then if they want to commit suicide, they'll take too many of it and they'll never wake up, and that'll be the end of that. Okay, so you want to make sure you understand this, that although all states refuse it, all states are not with this whole physician-assisted suicide thing. It's a thing that happens, and you have to do it if your patient really wants to die. Right? And of course, you want to watch out for, is the patient depressed? Is the patient medically, competent, mentally capable, etc., etc. Next one, though, this one is not mentally capable, right? So this is now a patient who is suicidal, right? So now you assess the seriousness of the threat. How do you do that? How do you assess the seriousness of the threat? So that's discussed in psychology, right? In the psychiatry section under psychology, if a patient is suicidal, to assess how serious their suicide is, you ask them questions like, have you decided how you're going to do it? Do you have a plan, right? Do you have a plan on how you're going to commit suicide? Do you have a weapon to commit suicide? You're also going to check how many times they've previously done it, right? If it is serious, if they have a weapon, they have a plan, suggest that the patient remain in the hospital voluntarily. Patient can be hospitalized involuntarily if he or she refuses, though. Right? So suicidal patients will be hospitalized, period. Either they can agree to it, which would be great, make things easier, or they can deny it, but then I'm still going to have to hospitalize them. Okay, so this is a very important question that, of course, again, occurs. These are all important questions, they all occur, but you want to make sure you don't, get it wrong. Don't let the patient go home and then go commit suicide, because then the court is going to come after you. They're going to look through your notes. They're going to look through all the other doctors' notes. And if any of the other doctors wrote down the patient looks pretty suicidal, they're going to question you. Why'd you let that patient go home? And you won't have an answer. Okay? Patient states that he or she finds you attractive. And that's like the number one reason I go working out, because I want my patients to find me attractive. That'd be great. But this is talking about, like, for me, if a woman finds me really attractive, right? And that's going to be such a terrible position to be put into. In New York, there's a doctor known as Dr. Mike, and he has his own YouTube channel. Check him out if you haven't heard of him before. He's a really good-looking doctor, very fit, all of these things. And he's here in New York. I've never met him, though. And he's got a YouTube channel with millions and millions of followers. He's very, very popular. He's been on every kind of TV show, this and that. He does a really good job. I'm sure he goes through this on an everyday basis, right? So what do? Your patient tells you they find you really attractive. You ask direct, close-ended questions and use a chaperone if necessary. Romantic relationships with patients are never appropriate. It may be necessary to transition care to another physician. So this is a very unique thing, right? It's so awkward and so unique because look, A chaperone, that almost never happens. You never bring a chaperone in to talk to your patient. And then we already saw two scenarios where you do not send it to another physician. You don't send the patient to another physician. This is the one case scenario where you do. Okay, so if a patient came to me, and regardless of how attractive she might be, if she finds me attractive, then I'm gonna make sure I bring in another patient with me. Sorry, another doctor with me, not another patient, a chaperone, another doctor or a nurse, anyone else with me, because I don't want to get into trouble where she later on files a case of sexual assault, right? Sexual anything, right? Or goes ahead and says, "Oh, yeah, Amir and I were dating, and this all started after after I was his patient or something." Because then I'm gonna get in trouble and I'm gonna lose my license and I'm gonna get kicked out of the hospital, and it's all just gonna be really bad, right? So my cousin was over yesterday. He's a doctor here in New York, and he was telling me about chaperones as well, but for a whole different scenario. The one that he was telling me about to bring a chaperone is with drug-seeking behavior, right? A patient who has drug-seeking behavior. I don't remember if that's one of the patient. Pharmaceutical company requests non-emergent procedure. Yeah, I don't think one of these is a patient that requires treatment not covered. This could be one. Invasive test. Patient is upset. Patient is angry. Blah blah blah. Right. So if you get a patient who has drug-seeking behavior, right, they just want opioids from you, no matter what. Give me that codeine. Give me that whatever. You bring a chaperone for that too, right? Because these patients will do anything to get their medications, which means they can assault you, or they can assault themselves and say you did it, right? Just to get you in trouble, just so they can blackmail you, right, with your own license, tell you that they're going to blackmail you, and then get the whatever medications they need, right? So the problem with this attractive thing, right? A patient finds you attractive. Where'd it go? Yeah, this one. A patient finding you attractive. The problem isn't that, romantic relationship, blah, blah, whatever. Dating is always confusing, right? Dating is always confusing. Someone can use you in a normal relationship. So here, now this patient, I'm using myself as an example. So the woman that finds me attractive might want to use me because she has drug-seeking behavior, right? So she might be telling me that she finds me handsome. She might, whatever, she's being flirty with me, because later on, all she wants is for me to prescribe her opioids, right? So having a relationship is not going to work out here because it's just a relationship of being used, right? And that's terrible. A chaperone is just anyone else that's there to watch and guide. That's literally all. Like you could Google the word chaperone. The term itself is used most commonly back in high school, where you go on trips, right? All these kids are going on trips, not even high school, like junior high school or elementary school. Everyone's going on a trip to maybe a zoo. So a chaperone is when other parents also join in, because there aren't enough teachers on one school trip, so other parents also join in just to make sure everyone's working correctly, right? And in step one, in first aid, there are chaperone proteins. Chaperone proteins, their job is to maintain the shape of a protein so that it doesn't break. All right, so hold the protein, maintain its shape, take care of it until we need to use it. Right, take care of it in messenger RNA until we need to use it. So chaperone is just other people there that are just here to watch and make sure everything's okay. They don't talk though. The chaperone is just going to be, maybe I'll bring in another nurse with me, right? So I'm here talking to my patient, and the nurse is just standing there watching, right? Another medical student can be a chaperone too, right? So just the medical students just chilling, watching, observing what's happening. And worst case scenario, I can bring in another doctor. But this is my patient, so I'll be talking, not the chaperone. All right, so that's very important. Bringing in a chaperone saves a lot of time and a lot of trouble. The next one, though, is the opposite of that. A woman who had a mastectomy now comes telling you that she feels ugly. Okay, so first of all, she just survived breast cancer, so that's amazing, right? Got a mastectomy, now she's alive, she's not going to die. When a patient comes in telling anything bad about themselves, not just, I think I'm ugly now, or I'm really unattractive now, you got to remember the right human things to do, right? Can't be rude, can't be mean, can't tell them, yeah, you're right, I agree. The most important thing to do, anytime someone comes and shares feelings with you, right? And as humans, we're not very good at managing relationships, right? A lot of relationships don't work out very well, and I'm talking about dating and marriages, because we're not good listeners, right? You gotta listen. And the only way to listen is when someone comes and tells you something bad that's happening or something bad that they're feeling, you ask them why. That's listening. Not be like, nah, man, don't feel like that. Do this and that. No, that's the wrong thing to do, because now you're telling them to be you, and that's not what's happening here. This person came for you to listen, not to hear you. Okay? So this patient, you find out why the patient feels this way. Do not offer falsely reassuring statements. Very important thing to watch out for. Right? This is very common in all cultures, actually, but definitely in the American culture, right? So you might get like, there are many people who are famous because they had acid thrown on their face, right? And not because they're not famous just because they had acid thrown on their face, but they're famous because they went ahead and they fought back against it. They stood up for what's right. They did all the right things, and they got the person punished. And now here they are putting their face on social media because they want to make a statement about the oppression many people feel, right? And how to equalize that, how to normalize that, how to correct it. So those famous people are often referred to as, oh my God, he or she is so beautiful, even though in all reality they're not. They had acid on their face. They had to get plastic surgery, and now their face does not look that good anymore. But we say you're the most beautiful person around because we feel bad for them and we feel great for who they are from inside. They're beautiful inside. But physically and strictly speaking, they're not anymore, right? There's a lot of people like that. That is falsely reassuring statements, and it's not a good thing to do that. It's not a good thing to do that. It only causes harm. You don't need to call someone beautiful, right? There's other things. You could call someone strong. You could call someone powerful. You could call someone so motivational, right? You're amazing. You don't have to go ahead and say, no, you are so beautiful, when they really aren't, right? And this person, this woman that came in after a mastectomy, she feels not ugly. She feels unattractive, is what it should say. She feels very unattractive now, and she's got a point in feeling that way, right? She's not entirely wrong in why she feels that way. I get it. If she feels that way, she feels that way. We don't get to pick how she should feel. It would be wrong for me to say, no, you're still very attractive, right? For multiple reasons. First of all, that's like kind of flirty, and I can't say that to a patient. And two, because I'm just false reassuring. She doesn't need to hear that from me. She just needs to be asked, hey, why do you feel that way? And she's going to share why she feels that way, right? She's going to tell you, oh, all my friends, they have nice boobs. I don't. And they're all married, and I'm not. And I don't feel like I'll find a husband. Okay, well, at that point, now you're stuck, right? And they don't tell you the next step of what to say. What's the next dialogue from there on? Because now you're just like, holy shit, what do I do now? So at that point, you just got to talk to them like, you survived breast cancer. That makes you a lot stronger than everyone else, who, all your other friends who, sure, they might have attractive bodies according to you, but, they're married too, but they're not as strong as you, right? That is a true statement. That is completely fine, and it might even motivate her. But there really isn't much else you can do for this patient, though. There really isn't much else you can do for this patient, and if she wants to get plastic surgery and get implants, that's something that she's going to bring up, not me. Right? It's not an option that I'm going to be like, well, have you thought of getting an implant? Because if I say something like that, if I offer that woman that option, then I'm kind of agreeing with her, right? I'm like, yeah, you're right. You're unattractive. Do you want to get an implant? So that's wrong of me to do too. So you just go with the flow. Just listen, and do as a patient requires. And don't lie. Don't give false reassurance either. Next up is a patient is angry, which is a very common thing, right? Especially the specific one. Patient is angry about the long time he or she spent in the waiting room, right? So if you apply for any kind of job here in a hospital, like as a nurse or as a scribe, anything like that, they ask you, have you dealt with this kind of scenario before? And how you deal with it is exactly like this. You acknowledge the patient's anger, but do not take the patient's anger personally. Apologize for any inconvenience, and stay away from efforts to explain the delay. No excuses. So a patient came up to me. She's like, man, I waited an hour and a half to see you. Last time I came, I waited 2 hours to see you. Like, why do I even get an appointment for 12 o'clock if by the time I'm going to see you, it'll be 2? Next time, give me an appointment for 10. My immediate response will be, look, I completely understand that. I get it. You did wait a very long time, and you were here by 12. And I'm really sorry that you had to wait that long. But now that I'm here with you, let's get this started. How can I help you? This patient will not want to waste any more time crying to you about how long they had to wait because they've already waited and wasted a lot of time. They'll go ahead and just tell you. They'll tell you, hey, I'm just here for my refills, man, or I just need to get my blood pressure checked because I've been feeling real dizzy. Whatever it is they want to say, they'll go ahead and tell you, and you'll move on with life, and that'll be it. Do not give excuses. Don't be like, yeah, I got called into the ER, I had to take a phone call, I had a family emergency, I had a car accident, blah, blah. None of that matters. No one cares about your sorry life, whatever your excuse is. This person is frustrated, and an angry person does not want to hear excuses. An angry person wants to hear sorry, and then the angry person wants to get the help that they came for. Okay? Patient is upset with the way he or she was treated by another doctor. Right? So some patient is upset with how they were treated by another doctor. Is that really my problem? No, right? So suggest that the patient speak directly to that physician regarding his or her concerns. If the problem is with a member of the office staff, tell the patient you will speak to that person. All right, so two kinds of scenarios here. So the first scenario is, let's say this patient that came to me had a different PCP before, and that PCP was too flirty, maybe too touchy, maybe too mean, maybe too busy. Could be one of any things. Point is, it has nothing to do with me. So don't tell me this, right? So if someone came and told me all these things about that patient, I'd be like, wow, that's really weird. Maybe you should go talk to that doctor about it. That's it. And then we move on, right? Now, the second half of this one said, if it's something with the office staff. So maybe now it's my clinic, right? And I have a secretary, I have 3 scribes, I have a desk person, whatever. And maybe one of them was really bitchy or rude to her. Not listening, not getting off the phone for her, telling her, can you just sit down? Any kind of rude remark. And this patient is telling me about it, I'll tell this patient, hey, you know what? Thank you for bringing that to my attention. Who was it again? I'll get the name down, really making you look serious. And I'll be like, all right, let's get you what you came here for. And then I'll have a chat with this person as soon as I can. Thank you for bringing that to my attention. And that's it. People want to see results. People want to see sorry. People want to see acceptance of what they feel. And that's it. No justification. Gotta accept what a person feels. Accept how they feel, because that's how they feel. That's it. Doesn't matter. You feel certain ways sometimes. You don't want someone to come up to you and be like, stop feeling that way. I want you to feel like this because that's how I feel. Too bad. We're different people. All right? An invasive test is performed on the wrong patient. Regardless of the outcome, a physician is ethically obligated to inform a patient that a mistake has been made. So if some invasive test was done on a patient, and that invasive test actually helped the patient, you still got to let them know. Okay, so what were we talking about here? So let's say you were supposed to get a colonoscopy on a patient in room 2, and instead you went ahead and did a colonoscopy on the patient in room 3. And you did that colonoscopy on that patient in room 3, and you found 5 polyps. And then later on, that patient is going to be helped with those polyps, right? Doesn't matter. That patient wasn't there for a colonoscopy. Maybe that patient was just there for an ECG. Okay, so now you have to go tell that patient, hey, so I know we knocked you out and we did your colonoscopy, and this is what we found, but I know you were only here for an ECG, so I had to make sure I come up here and apologize to you and let you know that this has been done. And all of this is only going to lead one place. That person is going to go home, that person is going to call a lawyer, that person is going to try to sue you, and you're probably going to lose money. So you make a mistake, you pay for it, that's it. Okay, as great as it is to be a doctor, just remember everyone is always trying to make money off of you or get drugs from you. So it's pretty hard sometimes. A patient requires treatment not covered by his or her insurance. And that's very unfortunate, right? That's very unfortunate. Never limit or deny care because of the expense in time or money. Discuss all treatment options with patients, even if some are not covered by their insurance companies. Right, so let's say I have a patient and they have an insurance company A, and they need this treatment done, but I know insurance company A doesn't pay for it. I'm still going to go tell this patient, hey, this is the treatment you need to get done. Right, and then they'll find out their insurance doesn't cover it. Well, now it's up to them to see what they want to do. Will they pay for it out of cash? Will they take a loan for it? Will they try finding another insurance company? Or will they ask for another doctor to do the treatment, right? Maybe another doctor or another state or another country can do it much cheaper than they can get it from me. Okay? So never hold back some kind of treatment option just because you know this patient can't afford it. You don't know that. Maybe they can't afford it. Maybe they'll afford it somewhere else. Maybe they can do something else about it. Now we have a 7-year-old. So a 7-year-old boy loses a sister to cancer and now feels responsible. Okay, so at ages 5 to 7, children begin to understand that death is permanent, right? That all life functions end completely at death, and that everything that is alive eventually dies. Provide a direct, concrete description of his sister's death. Right? That feels so fucked up, right? But no, you have to do it. This kid thinks that his sister died because of him. The only way you can convince him, the only way you can get him to understand it wasn't him, is if you tell him how his sister actually died. Right? So you'll tell the sister, look, your sister had cancer of the pancreas. The pancreas has a lot of enzymes that can really hurt you from inside. Her cancer made her produce so many enzymes that her body was flooded with those enzymes, and she killed herself from inside, and she died. Something along these lines, right? I mean, you got to make sure it's not too painful to hear it, but at the same time, it should make sense, and it should clarify that he didn't cause her to die. Okay? Avoid cliches and euphemisms. Don't use cliches. Don't say anything serious. I mean, don't say. So what's a cliche? A cliche is something like everyone has to die, right? Don't blame yourself for this. And these are all cliche statements. A cliche statements are what you generally hear in TV shows and stuff. Don't say anything like that. Just use facts, okay? Reassure the boy that he is not responsible. Identify and normalize fears and feelings. Normalize. Don't call fears and feelings weird. Don't make fun of fears and feelings. Don't say that your fear or feeling is stupid. No, normalize it. It is normal to feel the way you feel. It is normal to be scared. Right? Just gotta let the kid know everything he's feeling is normal. Encourage play and healthy coping behaviors. Right? So remembering her in his own way. Maybe he has a toy that he used to play with her. He should go ahead and play with that toy. Okay, she's just not there anymore. It's a very sad thing, and it's very difficult to work with young kids, right? Pediatrics, but it's not just pediatrics, because this is also going to influence the parents, okay? Patient is victim of intimate partner violence. So some men are just fucked up, and some women are fucked up, right? It doesn't just happen one way. There are many women who are also very abusive, emotionally and physically, to the men they're with. To the man they're with, but I'm talking about multiple women who are with, their own man. Ask if the patient is safe and has an emergency plan. Notice that this isn't about a husband only, right? This isn't about a husband being the violence person. This is about anyone. Don't always assume that a man cannot be raped or that a man cannot be physically or emotionally abused. He can be, okay? So ask the patient if the patient is safe and has an emergency plan. Do not necessarily pressure the patient to leave his or her partner or disclose the incident to authorities unless required by state law. Now, state law, again, you don't need to know every state's unique law, right? I grew up in America. I don't even know every state's unique law. It's just not a thing you need to know. We're not lawyers. But if a patient tells you that she or he is being beaten up every day by their spouse, then you need to tell that patient to disclose that to the cops, right? That's like, you have to. If a patient is coming in with like burn marks and broken bones and fractures in places that don't make sense at all from the story that this patient is giving you, it needs to be told to authorities, right? Because it's only going to get worse, and you're going to get in trouble because you knew what's happening and you didn't do anything, right? Being a cop and being a doctor are very hand in hand. There's a lot of law involved in both things. Patient wants to try alternative or holistic medicine. Right, so alternative and holistic medicine are pretty big deals here. They've been picking up a lot in America lately. Holistic medicine is the use of things that don't target a specific issue. Like for diabetes, you're not going to take a medication that just helps you do your pancreas' job. Holistic medicine is holistic. It's your whole body. It's about everything. Eating correctly, having the right mentality, making sure your brain is working right. It's like a lot of psychological things in there. Working out correctly, it's clearly going to be a much more effective thing than the medicine that we all do. So generally speaking, you don't tell them to stop, right? So here we are. Explore any underlying reasons with the patient in a supportive, non-judgmental manner. Advise the patient of known benefits and risks of treatment, including adverse effects, contraindications, and medication interactions. Right? I told you guys I'm trying to become a doctor because my initial love in terms of career was to go into teaching. Right? I love teaching people. It's kind of what I'm doing here too. So this is another example of that, right? As a doctor, if someone came in asking a question about something, you teach them about it, right? And it's not common that everyone knows about it. A lot of doctors, I can go up to them and be like, so what do you think about holistic medicine? I was about to try it. This doctor might have no idea what I'm talking about, right? So at that point, what their job is to go ahead and search it up, look it up right there, read it real quick, 15 minutes, and then tell the patient, yeah, it looks fine to me. Just make sure you know that this can happen and that can happen, and you won't be able to manage X, Y, and Z, and I won't be able to manage what's happening with you because I won't know what's going on. But best of luck. And that's it. Akanksha is asking, we can only report child and elderly abuse? Not young, is it so? Like not adult ones? No, you can report any kind of abuse. You can report any kind of abuse. The only thing is child and elderly abuse are talked about because usually children and the elderly are unable to reach out to you for help, right? Children are going to be too scared to reach out to you for help, and they might not even know what to do. They're too young. They don't have that much of life knowledge. And elderly might be unable to tell you also because they're scared because they're going to be hurt later by whoever's taking care of them. So these two are usually people who are fearful of what's going to happen to them when they get back to home, so they never tell the doctor that they're being abused. So you have to figure it out by playing certain mind games. But a partner, a married person, middle-aged man or woman, if they need help and they come tell you that, yeah, I'm being abused, but it's okay, I love her or I love him and I'm happy here, you don't do anything about it. Don't do anything about it, but you do want to make sure they have an emergency plan and that they're safe. That's just always the first question. Are you safe? Do you feel safe at home? Do you have a plan if anything bad happens? That's silly stuff, but that's just the route that we take. Okay? And then, of course, if this patient keeps coming back because their injuries are getting worse, you just go ahead and tell the patient to disclose it to the authorities, right? But do not pressure them. You don't have to pressure them. In fact, if they want to tell the authorities, they'll do it. They'll do it, and they'll be there with you, and you could tell the authorities as well, but with their permission, right? You don't want to pick up the phone, call the cops, and be like, hey, I have this patient, and I think his wife has been beating him up every day. And then the cops come, and the husband is like, no, my wife isn't beating me up every day. There's nothing you can do anymore, right? So this is why at that point, you don't call the cops. You don't do anything. The patient himself has to. But for elderly and for really, really young kids and for the elderly, they can't help themselves. They're dependent. They're dependent and they're pretty much immobile and they're weak, right? So you have to help them. You as a doctor have to call the cops for these people. But for people who are not completely physically dependent, who have the ability to do what they need to do, like a husband and wife, they have to call the cops themselves. You don't do it, okay? Because the last thing you want is to call the cops and then the person denies it. So then you call the cops for no reason. A physician colleague presents to work impaired, right? I've never heard of this, but I'm sure it happens, right? People go drinking, have a late night out, have an early morning shift at the hospital the next day, and they show up. If impaired or incompetent, colleague is a threat to the patient's safety, right? Report the situation to local supervisory personnel. Should the organization fail to take action, alert the state licensing board. Basically, rat that person out. You have to, right? If this impaired, either drunk or high or whatever this patient is, if whatever this physician is, if this drunk or high doctor goes around trying to take care of patients and orders the wrong medications, gives the wrong treatment, etc., people can die. Right? People can die. So you got to report it. And it only makes sense, right? Report your colleague. Now, next one says, patient is officially determined to suffer brain death. Patient's family insists on maintaining life support indefinitely because the patient is still moving when touched. So you as a doctor know that this person is brain dead. His brain has died. Okay, this person is comatose and his brain has died. But the family members are like, no, keep him alive. Look, when I touch his hand, he closes his fingers, etc. Gently explain. Okay, very important thing here, right? Gently explain. Gently explain to the family that there is no chance of recovery and that brain death is equivalent to death. Movement is due to spinal reflex and is not voluntary. Bring case to appropriate ethics board regarding futility of care and withdrawal of life support if necessary. Generally speaking, the first half should be enough. If family members all think that this person should be kept on life support because they're moving when you touch them, tell them that he's only moving when you touch them because it's a reflex. It's just happening because you turned on a certain nerve. They will never move because they wanted to. They can't want things because he's brain dead, and brain death is equivalent to being dead. It's a very difficult conversation to have with people, and the reason it says gently is because you can explain gently, but people won't listen gently, right? Emotional people, emotional family members, maybe it's the wife or the husband. This person might get all up in your face, really mad, and be like, excuse me, what the fuck did you just say? Do you want me to kill my spouse? Do you want me to kill my kid? Whatever the reason is, whatever the relationship is, you have to maintain your composure, okay? And that can be very hard. You gotta have no ego. You can't have an ego. It's just the way to live life. There's no point to having an ego. It just makes no sense. And if you're trying to be a doctor, you can't have an ego. If a patient came up to me, real up to my face, real strong, trying to beat me up, looks at me like, excuse me, what the fuck did you say? You want me to kill my wife? I'm just gonna be like, yeah, man, that's basically what I'm saying. Like, it's the best thing you can do. And that's it. Like, you're the doctor. You don't need an ego. You are who you are. Okay? A pharmaceutical company offers you a sponsorship in exchange for advertising its new drug, right? So what happens is when you get a clinic, you get pharmaceutical promoters that come to your clinic, right? They'll bring food for you because they're going to take your time, up to 45 minutes maybe. You sit down with them, you eat the food they brought, and they'll talk to you. Hey, so our company came up with this new medication. It works really well for blood pressure. It works better than X, Y, and Z, which are the other drugs you might be offering, and they know how many blood pressure medication people you have. So they'll be like, can you start giving this medication to patients and let us know how it's working out for them? And you'll say, sure, that's it. They're not supposed to offer you any kind of sponsorship because now they're forcing you to give that medication to patients who you might not even deem need that medication. Reject this offer. That's it, right? A pharmaceutical company can come to you and be like, hey, I see you have 300 people who take blood pressure medications of all kinds. I made this medication and it works like this. Can you give this medication to everyone you deem that would benefit from this medication? And your answer is going to be, yeah, sure. But if the same person said, can you start giving this medication to all your people who have any reason to benefit from this medication, and we'll give you $5 for each patient that takes this medication, you reject it. That's a sponsorship, right? You're getting something directly for each patient you put because now you're incentivized, right? Now you have an incentive to go give this medication to patients who don't even need it. So you don't go ahead and accept it, okay? So reject this offer. Generally, decline gifts and sponsorships to avoid any appearance of conflict of interest, right? Are you giving people medications because you know it'll help them? Or are you giving them medications because you know it'll help you? The AMA Code of Ethics does make exceptions for gifts directly benefiting patients, gifts of minimal value, special funding for medical education of students, residents, fellows, grants whose recipients are chosen by independent institutional criteria, and funds that are distributed without attribution to sponsors. Right? So if a company wants to give money, we'll take the money, but we're not going to say what company gave it. We're not going to advertise you. Like, thank you for the money. You're just donating, right? I don't need to advertise you. Thank you. We appreciate your money. So that's what they're saying in that last sentence. Now, gifts of minimal value. I mean, a lot of you might have already seen. There was this one question on UWorld a long time ago where this patient came in with his wife and he offered 3 different gifts to the doctor, right? One of them was tickets to a game, a baseball game. The other one was a drawing that his daughter made or something. And then I think the third one was like a bottle of some liquor or something. He had to reject everything besides the drawing. He kept the drawing because the drawing had minimal financial value. But he couldn't take the tickets because they have financial value. He couldn't take the alcohol because that has financial value. And by accepting certain gifts from patients that have financial value, you allow the patient to potentially think that, okay, I gave you $100 gift. You better treat me first today. I gave you a $200 gift. You better not make me wait 2 hours today, and so on and so on. You don't want to give that power to a patient, but taking the drawing is fine. The drawing only took heart, right? It took some time, but it didn't take hardcore financial investment to make that happen, so you accept it. Patient requests a non-emergent procedure that is against your personal or religious beliefs. Provide accurate and unbiased information so patients can make an informed decision. Explain to the patient that you do not perform the procedure but offer to refer him or her to another physician. And this is basically talking about abortions also, right? So a lot of patients will not, offer an abortion because they don't believe in it. Some physicians won't offer an abortion because they don't believe in it, because of their religion. Some physicians won't even offer a hysterectomy because they don't believe in it, right? Doesn't matter what you believe, you still provide the right information, right? Doesn't matter what you believe, you always pick the correct answer on step 1. Just like that, doesn't matter what you believe, you tell the right information to a patient, and if they want to get a procedure done, and it is good for them, but you don't offer it, you refer them to someone, and that's it, okay? What you don't do is tell them to not get it done. What you don't do is preach your own religion. Don't preach anything, all right? So that's not the job of a doctor. This one is pretty interesting. So you got a mother and a 15-year-old daughter. Now they're unresponsive following a car accident and are bleeding internally. You call the father, and father says, do not transfuse because they are Jehovah's Witnesses. Now what? So this is pretty, confusing, to be honest. This is probably the most confusing thing in this entire list of things. So the book says, transfuse the daughter, but do not transfuse the mother, right? So the daughter is a minor, so you don't transfuse her. The mother, you transfuse the daughter because she's a minor, but the mother you don't transfuse, and the mother might actually die, okay? So emergent care can be refused by the healthcare proxy for an adult, particularly when patient preferences are known or reasonably inferred, but not for a minor based solely on faith. Alright, so if a minor needs blood transfusion and they are a Jehovah's Witness, who they don't believe in blood transfusions, it's against their religion, you still do it for the minor. But look at this question from UWorld. It says a 6-year-old girl and her mother are admitted to the trauma center after a motor vehicle accident. When their father is contacted, he says they are Jehovah's Witnesses and that he is on the way. The father hangs up before the doctor can relay any specifics or ask questions. Repeated attempts to contact the father are unsuccessful. Neither the mom nor the girl carry any documentation to confirm this. Remember, it's neither nor. Okay? Either or, neither nor. Neither the mom nor girl carry any documentation to confirm this belief, and both are unresponsive. If both patients require blood products, what is the next appropriate step? And here it says, administer blood to both patients. That was UWorld. Physicians must always save a minor. The mother has no proof of being a Jehovah's Witness, plus the father is out of reach. Okay, so the difference here in this question and the one that's in UWorld, the first aid one and the UWorld one, it seems like the trouble here is that in first aid, this father that's saying do not transfuse because they're Jehovah's Witnesses is standing right there. He's there, he's present, and he's listening. So even with him there, you're still going to transfuse the 15-year-old girl. But in this UWorld question, where the father is unable to be contacted, even though he already said they're Jehovah's Witnesses, you apparently still administer blood to both. And that's kind of silly to me, to be honest. Like, it feels to me like if I was taking the test and there was an answer choice that said give blood to the girl but not the mother, then that's the answer choice I would pick. Because the father already responded and said they're Jehovah's Witnesses. Now, the other thing they're teaching you here, though, is that Jehovah's Witnesses, right, they all have this ID card they carry that says they are Jehovah's Witnesses, right? The lack of this documentation, which is given in the question, right? In the question, neither mom nor girl carry any documentation to confirm this belief. If you don't carry that Jehovah's Witness card, you're not a Jehovah's Witness. So that's how this question was justified in saying that you give blood to both of them. You save both of them. There's no reason for you to believe they are Jehovah's Witnesses. You're calling the father. He's not even picking up anymore. Okay? But if the father is there, right, or there is documentation saying they're Jehovah's Witnesses, you still save the girl. You still save the minor, because, religion is one of those things that you, like, brainwash your kids as they're growing up, right? But true religion is the one that you pick to follow, right? Once you become 15 or 16 or whatever age where you're into figuring that out, you're going to learn about your religion and you're going to go follow the religion you want to follow. And you might choose not to follow it, right? Many adults don't even say, well, they say they follow a religion, but they don't, right? So everyone does things when they feel like doing it. This 15-year-old girl might not want to be a Jehovah's Witness anymore. She might not want to follow that religion anymore. And if she never chooses to follow it, then that's her life goal and that's her life decision. We're going to save her life. The mother is a Jehovah's Witness and it's been clarified by the father. She's not going to get the blood transfusion. If she somehow lives, then fine. That's it. Alright, so very, very important to watch out to see the difference between the first aid scenario and the UWorld scenario and understanding how Jehovah's Witnesses work, because that is a thing on step 1. Last thing here is a child presents with injuries inconsistent with parental story, right? So that rings a bell for calling CPS, right? Child abuse. Contact CPS, Child Protective Services, and ensure child is in a safe location. Physicians are required by law to report any reasonable suspicion of child abuse or endangerment. If possible, try to seek permission from the parents to interview the child alone. But if they don't allow that permission and they're like, no, you can't talk to my kid, and they try leaving, you stop them. They can't leave. And you call the cops. They can't leave. Okay? The reason they can't leave is that if he runs away, the father or mother runs away, the parent runs away, that's okay. But they can't leave with the child, right? Because now you don't know the child's safe. So you got to keep the child with you. Keep the child safe, call the cops, they'll take care of it from there. So that's all of ethics, right? The last thing on this page is just about confidentiality. There really isn't much to say here. We all understand how confidentiality works. And if you just read this, it actually is enough. They talk to you about everything. The exceptions are being the most important thing here. I would do it, but I'm tired now. The exceptions are the most important thing here, though. These are the only exceptions to patient confidentiality. And those exceptions are generally what you're going to get tested on, so you make sure you read that, make sure you understand why those exceptions make sense. And then I'll just do this UWorld question with you guys. So it says, while having dinner outside, a physician notices one of his patients sitting at a neighboring table with her husband. Okay, so one of his patients are on a neighboring table with her husband. While exiting the restaurant, the patient approaches the table and exchanges some brief pleasantries with the colleague and nods briefly in the physician's direction, but says nothing to him. The physician acknowledges the gesture with a smile. Later, he asks the colleague, "How do you know her?" "She is a family friend who was recently diagnosed with breast cancer, and I have been worried about her. Can I assume she is a patient of yours and ask how she is doing?" What is the most appropriate response the physician can give to his colleague? Right? So basically, me and my friend, we're both doctors. We're having dinner somewhere, and one of my patients is there. And, we look at each other, we smile, we kind of exchange some kind of, "Oh, hope you're having a nice time," kind of, gesture. And my friend, who's also a doctor on another table, sees this. So he knows her, though, but she's my patient, not his patient. He comes to me, he's like, "Hey, how do you know that one? Is she okay? What do I do?" I'm going to say, no, I cannot say whether she is my patient. I can't even tell you if she's my patient. Done. If she chooses to tell him that I'm her doctor, that's okay. Because it's her life, right? I can't say if that's my patient. That's it. And we're done here. Like, we won't talk anymore about it. I made a mistake. I chose to say she is my patient, but I'm unable to discuss her treatment due to patient confidentiality. And I fucked up when I did that, right? I can't even give away any information, right? Never divulge any information regarding a patient's condition or treatment, and do not lie or confirm or deny whether something is true. So I can't even tell you if that's my patient. And that's it. And as a doctor, he'll understand what I'm doing. In fact, as a doctor, he shouldn't even be asking me if that's my patient. But people do stuff, okay? So that's ethics. I hope that's been really helpful. And whoever's taking their step 1 soon, best of luck with that. And I really want to hear success stories, right? So if people take their step 1 and it went great, please, come back and tell me. I'd love to hear if I was of any help, and I'd love to know that you guys did well. So keep up the studying, and thank you for joining, and I'll catch you guys later.